Hi, everyone. I would like to invite you our continuing quarterly CME series on lysosomal disorders. I am Ozlem Goker-Alpan. I'm the founder and chief medical officer of Lysosomal and Rare Disorders Research and Treatment Center at Fairfax, Virginia. Today, we're going to discuss an assessment of biomarkers in lysosomal disorders, but we're going to take them from a mechanistic approach. So these are my disclosures. And on today's discussion, we're going to discuss the rationale, the use of surrogate markers in patients with lysosomal storage disorders. And we're going to discuss few disorders while I am giving some examples. But before we start, we're going to review what is that ideal biomarker and discuss disease-specific and non-specific biomarkers, and also touch base with the review of novel technologies, especially with the advent of personalized medicine. And finally, we're going to discuss the utilities and limitations of glycosphingolipid markers, the markers that we have the most evidence on. And then we're going to discuss them in the context of Gaucher and Fabry diseases. Before we start going into the specifics of the biomarkers, I want to actually open this discussion with the description of rare disorders from the FDA point of view, because we're going to take the biomarkers from the clinical trial to the clinical grade during this lecture. So any rare disorder or an orphan disease is described by the FDA is any condition that affects less than 1 in 200,000 persons in US. While in reality, most rare disorders are much rarer than this, as collectively rare disorders actually constitute a public health concern, and almost 1 in 10 Americans are affected by a rare disorder, and most of them actually do have unmet needs, especially in the development of novel therapies. So how do we need to approach a rare disorder to understand the basic pathophysiology to develop novel therapeutic options? Okay, so we start with the natural history, that we understand the true natural history disorder related to the pathophysiology. And if it's a given drug, we understand the mechanism of action and effects of intervention, obviously, to the disorder. And then this brings to efficacy trial study design. And this starts with the earlier phase studies, and then the IND enabling actually leads us to the clinical endpoints, which actually can be used or are occasionally used as the clinical endpoints in the real life. So for FDA, what constitutes effectiveness? What is a clinically meaningful endpoint? Actually is a direct measure of how a patient feels, functions, or survives. However, recently there is a tendency to use surrogates for the accelerated approval of the medications for rare disorders. Um, what is a treatment benefit? Is from a drug, the treatment benefit is the impact of treatment on how a patient survives, feels, or functions, versus from the surrogate endpoint, where it does not directly describe how a patient feels, functions, or survives. A surrogate actually will give an idea to multiple steps that we had discussed: the pathophysiology of the disorder, the mechanism, and also can explain the mechanism of action of the drug, and also can actually shed light to the survival or function or how the patient does in a shorter period of time. So the actual rationale of using a surrogate marker or a biomarker in understanding disease pathophysiology and the progression is, I usually give the iceberg as an example. So when we start seeing the clinical endpoints, and here, the tip is the iceberg, and this is when the clinical issues start with a patient. But up until that point, we have many steps that actually has happened, and is happening at multiple cellular and tissue level. So, if we think as a rare disorder, obviously genetic basis. With a genetic basis, we are going to take the gene change or the molecular change as the culprit, which leads to a change in the action or a function of a protein, and then this starts rolling the disease process. So when you take the biomarkers will be somewhere around the base of the ocean where the disease pathology has started, but it did not quite translate into the clinical endpoints yet. So let's start with a hypothesis. This can be applied to almost every single disorder. So at the beginning, the culprit of the disorder is a rare genetic disease here. The molecular change will lead to a deviation from the normalcy, which actually at the beginning is tried to be balanced by the body and tolerated to preserve the homeostasis. And there are multiple um, actions from the cellular level to keep the homeostasis. A cell death is one of them. The cells that are not functioning well uh, actually are doomed to die. So this general homeostasis of the tissue is maintained. However, as the disease load increases, this homeostasis cannot be maintained anymore. And then there is the evolution of cell and tissue specific temporal involvement with increased complexity. So the disease kind of a snowballs on itself. So basically, it is different from the starting process, but tends to achieve another form of the disorder. So, this is the disease propagation. And when you start seeing the clinical signs, and then the disease propagates on itself with the other pathways, such as the inflammatory and immune pathways, and then the downstream effect occur, which is can be independent from the initiation event. So if you think that the lysosomal storage disorders, at the end there is an inflammatory part of every single lysosomal disorder. If you think about the MPSs, if you think about the ones that significantly affect the central nervous system, there is the gliosis, neuronal cell death, so on and so forth, which moves the disease forward, which is quite different from the initial molecular change. So, as I gave example, the immune response, the inflammation is a great example of the disease propagation in lysosomal disorders. So, I just want to give an example here for Fabry disease. It is easier to understand the disease pathology in Fabry because kidney is an accessible organ for biopsies. Is that right? So if we think that the cellular GL3 deposits is the substrate deposition and the event that is secondary to the molecular change, that actually the disease forwards itself by the cellular injury damage. And then we are starting with the inflammatory process that goes to scarring, and then we have the organ failure and tissue involvement, and so on and so forth. So basically, this is the tip of the iceberg here and the cellular dysfunction here. So when we start seeing the biochemical activity, also the biomarkers actually take effect in the disease process. So we know that actually Fabry disease is notoriously uh, late to discover unless there is a family history. The reason is that because of the ubiquitous presentation, and mostly the treatment guidelines take organ damage as the primary starting feature or the rationale to treat the patients. But if we take these as the rationale, we understand that disease process is already too late into the progression, and there is almost a point of no return um, in those patients. Actually, the disease progresses regardless. So there are delays in starting therapy in Fabry disease. There is no study assessing the optimal age of ERT initiation, as Fabry disease is regarded as a adult disease. However, the complications do occur in adulthood, whereas the initiation starts obviously with a spectrum, but with the molecular change. So we know that there are no uniform guidelines and conditions and age to start ERT in the various countries. In general, the development of signs or symptoms related to the end organ damage in Fabry disease is an indication of start of ERT. For example, the development of chronic kidney disease, such as proteinuria, decreased glomerular filtration rate, evidence of cardiomyopathy, so on and so forth. So basically, these are the end organ damage rather than the culprits for the disease progress. So why we're discussing Fabry disease, obviously, if you may recall, Fabry disease is the poster disease where the surrogate markers are taken as evidence for the approval of ERT in United States. And there was a conditional approval that ended to be full approval after decades. The reason was obviously it wasn't how the patients functioned and felt and survived, because obviously this is a chronic, slowly progressive disease, but whether the biomarker, which was GB3 in the tissues, whether could be cleared. So if you take the whole disease process, the GLA deficiency and resulted GB3 deposition are the primary events for Fabry disease, and the downstream effects on lysosomal pathways further help disease progression. And the disease progresses with the activation of inflammatory and other immune pathways, leading to tissue fibrosis, scarring, and that represents cell propagation. And then these are while it is initially dependent on the starting event, the disease actually progresses as the independent event. So I always remind these to the patients, and then we discuss the point of no return to start the management and when we should start the management. So surrogate endpoints, as we discussed, could be used for a regular approval, such as the blood pressure, LDL, in diabetes, hemoglobin A1C. But with an accelerated approval, it is somewhat different than the regular approval, which takes about 10 years or more. But mostly the rare disorders are put on a fast track for accelerated approval. So why it is important? Because still the surrogate can be the ideal surrogate, but still there is some uncertainty of relationship with the clinical benefit. It is not well so established as the surrogates ordinarily used as basis of approval historically. The perfect situation for a surrogate endpoint is basically the disease. The surrogate endpoint is the intermediate step en route to the disease progression, and then non-specific treatment has no impact on relationship to surrogate and the outcome. So the rationale to use a surrogate or a biomarker for an endpoint is we know the treatment endpoints clinically are reached later. So long follow-up needed to observe the outcomes, and the surrogates allowed to read out the clinical results earlier. And especially there are ethical issues in stopping a trial early once the investigational product is proven to be superior based on other outcomes. And so we do infer results on clinically significant endpoints in cases where appropriate trials where these results are not ethically feasible. So when there is a strong evidence that there is a direct surrogate or biochemical marker is decreasing with therapy, and there are other evidence, then it's not ethical to continue the trial with a double blind, so on and so forth. And the unbiased clinical endpoints cannot be observed due to crossover to efficacious therapy. And approval and reimbursement decisions also in real life are also based on the surrogate markers. So there are different methods for surrogate development and validation. Obviously, there needs to be biological plausibility, and with the literature research, and then basically there needs to be an accurate prognosis of disease outcome that needs to be demonstrated at the individual level of surrogacy. And if there is an accurate association between a change in the surrogate endpoint caused by intervention, then this is the ultimate disease outcome that demonstrates a trial level surrogacy. So obviously, there is a little understanding change in the surrogates or the biomarkers. Um, on the biomarkers, and because after the advent or the start of precision or personalized medicine, actually what this was what we had been doing for rare disorders all along. The reason is some rare disorders are really really rare, so we treat N1 and we treat patients actually individually. So that brought the companion diagnostics for the development of novel therapeutics in personalized disorders. So, if you look at cancer medicine, such as foundation medicine, there is a tumor marker that is associated with a certain biologics or a treatment that is actually taken in each trial. So obviously, why are we using companion diagnostics in personalized medicine? So the reason is that cost of trial and error medicine obviously takes the precision medicine imperative for the targeted therapies. And bespoke therapeutics as the future of genomics medicine with customized and created products and provision of individualized therapeutic products, gene therapy, genetically modified cellular therapies, and antisense oligonucleotides do require other markers for the assessment of the therapeutic outcome. So I'm going to discuss a little bit about the novel technologies in the development of biomarkers and touch base about the omics technology. Obviously, when we look at the omics, we're looking at the structure, function, and organization of a living system, and which defines biological systems. So the basic biomolecules are from genes, proteins, and metabolites, and whereas there is a special relationship between these molecules. So none of this gene product and the metabolite is an island. So they do have effect and result with the as a whole organization of the system. So omics strategies actually enable us to understand a given biological system at different levels. So truly the high throughput sequencing technologies or the high throughput technologies in general brought a new dimension to the omic technology. So we start with genomics is an example, next generation sequencing based strategies and based size on the genome. So we do an NGS, we do have the all exome sequencing. And here the issues now we are facing is the variant interpretations and clinical validity are the challenging aspects of NGS with variant of unknown significance and whether we don't know it's benign or impactful to the structure and the function of the protein. Even though crystallized structure can give us ideas, we really don't know whether the change will be tolerated or will be impacted. There is an example here, but that's a great example. I just saw a family with a suspected neurodevelopmental disorder associated with autism in three kids. And then the whole exome revealed one likely pathogenic variant, and it was in the gene that is related to Sanfilippo A. So, and we had to do studies, including GAGs and other biomarkers to assess whether this was tolerated benign or a disease causing a mild variant. So we decided actually based on the biomarkers that this was a benign and tolerated variant rather than this is a disease causing variant at a milder level. So I'm going to switch to transcriptomics from the genomics. Obviously, the gene expression in a cell tissue can reflect the functional state. And then we're talking about the RNA transcripts here, such as R, M, and tRNA and non-coding RNAs. And the quantitative analysis of the transcriptome can be performed with either microchips or RNA sequence, the RNA-seq. There are examples to that in animal studies, such as the circadian transcriptome analysis or MPS2, that impact the HRID sulfatase levels. So epigenomics is the chemical modifications of DNA, histones, non-histone chromatin, and nuclear RNA that may affect the gene expression without altering the base sequence. And it's one of the probably the least understood aspects of the genomic medicine right now. Obviously, the mass spectroscopy techniques actually brought a new dimension to the development of novel markers that are validated in both at the clinical and at the trial level surrogacy. So the as we know, a metabolome is the set of metabolites present in a given biological system at a given time. And based on the biochemical characterization of the metabolites and their fluctuations related to the internal genetic or external factors or the environment. So we're looking at the whole biological system with the metabolite, with the impact of the environment or which body fluids actually these metabolites are excreted in. So on the right hand side, so basically you're looking at the identification of a reliable biomarker profile for the diagnosis of Gaucher disease type 1 based on the metabolomic approach. So there are different markers included here. So the main gap of these omics or high throughput technologies now, basically the noise. So since we are looking the system as a whole, there is an issue of validity and reproducibility. And since the end result of almost every single disorder is now the inflammatory system and immune dysfunction, so on and so forth, it is very hard to differentiate and to have the control system for this kind of experiment. So obviously there is another issue whether how clinically relevant the findings are, such as any variant of unknown significant. And this becomes actually makes it assessment of correct phenotype, which is very, very important. And usually at the trials, 0 and 1 usually lumped together, which means that the patient is not affected versus the patient is not mild, is very mildly affected. And so it is not even imperative to take into the consideration of the symptoms. But this is a big mistake because it is a big difference between not having affected and starting with 1. And this is probably the most important patient we need to understand why 0 is becoming 1. So while designing a trial is to differentiate and to get rid of the zeros and then put the ones that we know they're affected and lumping them together so that the phenotypes are not cluttered. So this actual table describes some of the mass spectroscopy based metabolomic markers in the LSDs that we recently started using both at the trial basis and also at the clinical level. So obviously lyso-Gb1 or sphingosine, which is the deacylated form of glucosylceramide, is actually I do use pretty commonly in the in the clinic for short-term decision marking. And there are other neurodegeneration markers, such as glycoprotein non-metastatic brain that is used in some of the current trials in Gaucher disease. Obviously, the GAGs, which had been measured in before, now in the high throughput manner, can be used in screening or other, in more sensitive manner in the MPSs, and similarly, sulfatides can be done in MLD in a high throughput manner too. So I'm going to little bit switch the gears and start talking about the clinical applications of biomarkers. We're going to talk about the sphingolipidosis here because the pathway is pretty straightforward and we can actually compare and contrast few disorders depending where they are at the sphingolipid pathway. So we started talking about Fabry disease. I'm going to continue with Fabry disease since Fabry disease is the disease that was the first that led the use of surrogate markers for an approval process. So we're going to talk about GB3 clearance. It was first evaluated as a surrogate endpoint for placebo-controlled ERT trials that led to the regulatory approval. And substrate accumulation, including GB3, and the lyso-GB3 can be readily detected in the urine and other tissue samples. And the placebo-controlled trials in classic Fabry patients have consistently shown that within 6 months of the start of the therapeutic intervention, uh, there is reduced levels of both plasma and urinary GB3 and the by biopsy capillary endothelial GB3. So the surrogate marker that had been initially used, actually that's with the therapeutic response, there is a direct evidence that the biomarker has a role in it. So while glycolipid measurement in the urine may be helpful in attributing the renal pathogenicity or the phenotype, however, it is less useful for general screening process. So basically, GB3 has been used as a marker at the start of the approval for the ERT for Fabry disease. GB3 is not a specific marker for general screening. So it also increases in several disorders like in cardiac disease or renal disease. So if you're trying to do a mass screening using the GB3, that's not going to be your option. So we still don't understand the pharmacodynamics of the biomarkers we use in Fabry disease. So in young patients, such as the ones that are diagnosed through newborn screening, and there is evidence from the Taiwan experience, there is limited evidence of dose-dependent clearance of GB3 in podocytes over the 5 years of follow-up. So the surrogate marker does correlate with a dose-dependent clearance in the younger patients. However, as I said, the GB3 clearance has not been well established as an acceptable universal surrogate for beneficial and organ therapeutic effects. So to, moving from the GB3 to the lyso-GB3, which is the uh, deacylated lysosomal form of GB3, that is a very inflammatory molecule, and it is derived from the storage material and is related to the phenotype and disease severity. Why it is related to the phenotype or disease severity? Obviously, the inflammatory pathway that gets activated at the beginning actually is directly related to the end organ damage. And the elevated, as we know, elevated lyso-GB3 levels correlate with the cardiomyopathy and left ventricular mass index in men and the presence of white matter lesions in women. So basically, this gives us an indirect idea what the white matter lesions are coming from in Fabry disease. It's partially, at least, they are inflammatory in nature. So obviously, the podocytes, endothelial glycolipid deposits are correlated with albuminuria in pediatric patients. And similarly, if you give the mice the lysogb3, it results in the upregulation of whole inflammatory molecules in the kidney. So there is a direct evidence that lysogb3 is directly in the pathway that is related to the end organ damage in Fabry disease. So with tandem mass spec, you can actually find the isoforms that may be related to or suggested to relate with certain phenotypes such as cardiac involvement, kidney involvement. In this study, we were questioning whether the lysogb3 isoforms have anything to do with the immune hypersensitivity reactions that we see in patients with Fabry disease. So we couldn't prove directly, but we suggested that the elevated lysogb3 analogs may contribute to the further immune response and increase lysogb3 levels, decrease the efficacy of human recombinant alpha gal, secondly to the immune response in these patients, because we saw the patients who had developed immune response had very little dendritic cells, so they had a very inflammatory background to start with. So basically, these patients also had higher disease loads. So how do we use the glycosphingolipid markers in the short term as a short-term therapeutic monitoring tool? So in this study, actually patients were switched from one dose to another, and in this, if you see the middle graph, that the lysogb3 levels do correlate with the dose change in these patients. And however, the urine GB3 and the plasma GB3 levels were not as reliable as the lysogb3. Um, so this slide actually gives you an idea whether GB3 or the lipid markers could be used as screening tools for Fabry disease, even though there is some evidence that the lysogb3 can pick up um, patients with classic patients with who are male. It may inadvertently miss the female patients. Uh, so even though the Japanese groups actually tend to use lysogb3, lysogb3 is not a primary first tier screening marker for Fabry disease. So let's talk about a little bit non-specific disease markers for Fabry disease. So these are not directly related to the GLA deficiency, but these are the markers for the end organ damage. So this actually shows the organ dysfunction rather than the primary culprit. So we use quite often in the clinic, especially high sensitive troponins, and then the T2 marking with gadolinium MRIs for cardiac involvement. These are the primary markers for cardiomyopathy. LVC, GFR, cystatin C, creatinine are indirect markers for the kidney function in Fabry disease. And some other markers that we use, IL-6 and the other immune markers are too general, so we don't use that. However, we obviously use the cystatin C, and pro-BNP is elevated in actually not in subclinical disease, and our cohort indicates this actually gets elevated in as the disease progresses. So it correlates with the severity of cardiomyopathy, but it's usually the later stages. And almost all patients we follow up with cardiac involvement and Fabry disease, they do have increased high sensitive troponins. However, NTBP is also affected with other conditions such as kidney disease in general or lung disease. Actually, we have some patients with elevation of NTBP that we inadvertently actually attributed to the lung issues in younger patients without evidence of cardiac or renal involvement. So some other markers that we use is not included here. Is in the previous slide is galactin 3, which does indirectly correlate with the scar or the scarring scar tissue, and it may be related to kidney or the cardiac damage. So I'm going to describe, actually, present you two very similar presentation of the patients, and we're going to a little bit try to understand their clinical status with the help of the biomarkers. So the first patient, you see the cardiac MRIs and the brain MRI. So it's a 59-year-old classic Fabry disease, diagnosed around 30s, with at that day age, actually, at that time there was no known, the gene was not described yet. So basically that he was missing a whole chromosome area, and that corresponded to GLA. So he, as a classic Fabry patient, he has had kidney transplant. He has significant cardiomyopathy with bradycardia, right bundle branch block, ventricular hypertrophy, lateral infarct. So he also has aortic stenosis and concentric left ventricular hypertrophy. The MRI of the brain shows fusiform dilation of the distal basilar artery, which is not uncommon. And there is moderate obstruction on the pulmonary function test. He developed a significant left leg edema after a pathological fracture because of decreased bone density. And so this patient comes with shortness of breath. So basically, we perform a few biomarkers and try to understand where is his shortness of breath is coming from. So is it his heart, is it his lungs, or is it something else? So let's look at the cardiac biomarkers here. So it's with BMP here. So is, as you see, is increasing. We discussed this is something that increases when the disease gets advanced, and the high sensitivity troponin is also is mildly increasing from baseline. So there is, as you know, that these are the molecules that respond to ischemia. So basically, there is evidence that that's probably the concentric hypertrophy is getting worse. Galactin 3 has been elevated and has been elevated, and his plasma lyso GB3 is slightly increased. So either there is a treatment lack of response, or the disease actually rolls in itself because of the inflammatory nature here. As you see, the urinary GL3 is mildly changed too. The other kidney markers have been staying um, negative, actually is stable. So basically, that we attributed this to his, even though there is a change in lyso-Gb3, and we did some management changes, we attributed to this cardiac disease. So similarly, another patient that comes with shortness of breath and lower leg edema. So let's see where this is coming from and how we interpreted the results. He was diagnosed at age 13, and there is a deletion mutation of the GLA gene. So the first patient actually was missing the whole chromosome part, and he has proteinuria for the past 2 years, about 500 milligram per day. Had a quadruple bypass in December. That actually the angiography showed left ventricular hypertrophy. There is thickening of the aortic valve, and his EKG showed marked sinus bradycardia. So his after the quadruple bypass, he has not had shortness of breath, and his PFTs at that time showed moderate to severe restriction. He's continuing to have some diarrhea, bloating, and motility issues. That is due to his Fabry disease. He has had headaches and occasional vertigo. He has acroparesthesia, and he has fatigue, anxiety, and depression. As you see with the other patient, he has left ventricular wall thickening, and the pattern of myocardial delayed enhancement is unchanged. And there was prominent delayed enhancement infralaterally at the base that was still present, and there is moderately extensive non-specific T2 signal abnormalities in the white matter for both cerebral hemispheres and the few tiny old lacunar infarcts. So if you look at his biomarkers here, we discuss his plasma lyso-Gb3 since the start of the treatment has been stable. Actually, is had a little alteration, but has been going down. His cystatin C has been also stable. But if you look at his high sensitive troponins, is actually is recently very much increased. So that is due to ischemia. So we interpreted that actually is the malfunction of his stent, and we sent him from the office to the angio, and he had a cardiac cath, and he had a stent replacement. So let's review this correct statement for the glycosphingol markers and what find the correct statement. So basically, GB3 clearance is an established universal surrogate for the beneficial and organ therapeutic effect. Obviously, it is not, even though it's taken as a surrogate marker and the therapies have been approved with it, it is still not established. Urine GB3 can be used as a screening tool. It cannot because there are some other disorders which can elevate the urine GB3. And plasma lyso-Gb3 may be used to monitor therapeutic alterations, yet it does because it does respond to short-term changes in the either naive or patients who are not on long-term therapy. If the patient is on stable therapy more than 10 years, the lyso-Gb3 may not be that sensitive. The incorrect answer is the plasma lyso-Gb3 can be used as a first-tier testing for newborn screening. It is not a first-tier testing, but it can be a confirmatory testing after the screening test. So I'm going to switch the gears and spend a few minutes on the surrogate markers for Gaucher. I'm going to basically put the emphasis on the glycosphingolipid markers, but I am going to discuss the historical markers and their role in following Gaucher disease because it shows different mechanistic views of the disease process. So the first one, two, three, four, five markers that we had used previously before lyso-Gb1 was available, lyso-Gb1, aka sphingosine, is the deacylated form of glucosylceramide, and it is secreted from the larger organs. So basically, the ACE, ferritin, trap, they are all actually macrophage activation markers. And we know that chitotriosidase, which is an enzyme or chitinase that is actually is present in the macrophages to fight particularly with the parasitic infections. And I usually give the example. It is the to digest the shrimp shell. Um, so these are non-specific markers. These are the immune activation markers. We know that when the macrophages are activated, they start secreting all these markers that actually indicates part of the disease process, which is the disease progressing on itself. But if you look at lyso-Gb1, actually this is the that reflects the circulating toxic substrate. It was not readily commercially available, but now it is available commercially. But there is a caveat. Different labs have different cutoff points. So it is not something that is or apples and oranges. Actually, it is like apples and oranges. So basically, one lab results cannot be compared to the other one, and unless you are using a uniform lab. So these are the issues right now with the lyso-Gb1. So it does correlate with the severity of the phenotype and the genotype in an untreated patient. It is not increase in genetic carriers of Gaucher disease. So basically, it is something if you find one variant, if you cannot identify the other one, and the enzyme levels is at either the heterozygote levels or very mildly decreased, then to distinguish the carriers versus the effectors, lysogb1 actually is a good marker. And we know that in the homozygous untreated patients, lysog-L1 or GB1 levels were shown to correlate with the GBA mutation severity. So basically, patients that come with type 3, they do have at childhood, they do have universally 300 times elevated lysog-GB1 at diagnosis in our clinic. So basically, it does correlate with the disease severity. There significant elevations actually do occur in the more severe forms of Gaucher disease. And as you see, this is our data, and it does correlate with the organ size in the untreated patients. So I will give you another vignette. So we do have one steady marker for lysogb1, and we're going to try to figure out which belongs to which. So basically, you have received the levels of a lipid-based metabolite measured in blood for a given LSD. Then the metabolite is lysogb1, and if the elevation is 250 times over the upper limit, then your diagnosis is obviously Gaucher disease. So it is not, even though the non-specific immune markers can be increased, Niemann-Pick C, uh, it is not increased. GISO-GB1 is not increasing the other disorders. So basically, so let's just try to match the genotype and the phenotype. So basically, in a newborn, when we have during newborn screening, you measure 250 times. So basically, this is predicted either to be a neuronopathic type. We will not know whether it is a type 2 versus type 3. So when we try to match it, so these are actually real patient vignettes. So we're looking for two severe mutations. The B1 is a L44P and the REC delta 55. So is associated with a newborn presentation. So is a 3-year-old with a wide-based gait. So we're looking in a milder variant here with 300 times elevated is a 3-year-old. So we're looking into the B3, which is a R502C, is a reg. And and a 55-year-old history of lymphoma, extensive marrow replacement, who had stopped treatment about 15 years ago. So this actually corresponds to N370S, a reg 55, 55 base pair deletion as a recombination variant. So the B2 is a GD1, B1 is a GD2, and B3 is a GD3 patient in real life. So I'll talk about a little bit disease progression and close the talk with that. Obviously, we talked about the independent events and other epigenetic environmental factors that drive the biomarkers. So this is a great paper from Greg Garabowski's group. Manoj Pandey is the first author. So in the study, they found out the complement activation or the immune system that drives the disease. So basically, they measured the complement levels, and then it correlate with the lysogb1, and the lysogb1 increase the complement activation, and complement activation also vice versa increase the lysogb1 levels in animals. Also, this was shown in the human tissue and in the human in the human body fluids. So the limitations of the glycosphingolipid markers. So basically, it does correlate with the general disease severity, but it may correlate with the organ enlargement in an untreated patient, but it is not organ specific. So basically, we will not understand the extent of bone marrow involvement using lyso-Gb one levels in Gaucher disease. Obviously, it is a very inflammatory molecule, and you can indirectly hypothesize that there is going to be scarring because the lyso-Gb3 has been so high for some time in a patient with GD1 with high lyso-Gb1 levels. So, for patients on long term therapy, glycosphingolipid markers such as lyso-Gb3 might not change even though disease progresses because it's what's happening, the end organ damage, the organ dysfunction is progressing, but it may be independent or interdependent with the disease activity at the beginning. So if you see here, we did a small study in 83 patients with Fabry disease from our cohort, and we look at the validity of or the value of lyso-Gb3 in assessing cardiac disease. So basically, we have seen that it is increased more significantly in all the severe patients with severe cardiac disease, but it was increased in general. It was probably more specific for female patients. So if you see a female patient with high lyso-Gb3, it that correlates somewhat more with the clinical presentation. However, it was not specific for like aortic stenosis or the degree of ventricular involvement, so on and so forth in the stably treated patients. And as I said, the GSL markers may not correlate with specific organ involvement, so you will not understand whether there is more significant kidney involvement versus cardiomyopathy or other issues with the disease. So this is the general inflammatory marker that is related to the disease process. And as I said, the end organ damage continues in later stages of the disease, long-term therapy, despite the long-term therapy and lower GSL values. So basically, you can intervene the disease process even if the disease has progressed, and you can bring down the biomarkers to an acceptable level, which we may never actually achieve the zero because the disease will roll on itself. The organ damage will continue. So you're looking at the complications phase of the disease rather than the initiation phase. So this is very important to differentiate in management and treatment of patients with long disease courses such as Fabry disease or type 1 Gaucher disease. So as a summary, for the surrogate markers is disease heterogeneity and lack of short-term clinically meaningful endpoints are the major issues in most LSDs. A reliable biomarker is related to the primary disease mechanism and disease pathology, and that is not impacted by non-specific therapy. So we know that if we start ACE inhibitors for patients with Fabry disease, we may impact the proteinuria, but we will not impact the progression of the disease. Specific glycolipid markers, I like lyso-Gb3 and GB1, may correlate with disease activity and changes of therapy. So basically, it can be used for short-term therapeutic modifications. Lyso-Gb3 and lyso-Gb1 may be utilized in selective screening and monitoring of therapeutic changes, but they are not usually recommended as lyso-Gb3 we discuss as the first tier screening. And utility of biomarkers in early pre-symptomatic or minimally symptomatic individuals, and for this diagnosis and when to decision to intervene needs still be further explored. So neonatal screening actually is giving us the opportunity for the future to understand the value of biomarkers and how to use them in for starting, stopping, and managing the disease, meaning the treatments. So screening strategies using biomarkers in asymptomatics actually may reveal clues about the true natural history of the LSDs, and also the impact of other omics that we discussed, the epigenomics and other effects of the environment, why in some patients the disease move forward and while in the others actually stay at a indolent state. So a little bit the novel technologies, different omics strategies based on high throughput screening or mass spectrometry techniques are at different stages currently of technical analytical development. So there is not a uniformity. So we have more evidence from the mass spec as the clinical utility of these biomarkers, but still the controls and the background noise are the basically issues related to the biomarker development using the high throughput screening techniques. And but using metabolomics with mass spectrometry led to the development of validated biomarkers such as the glycosphingolipid markers or the isoforms in Fabry disease. And obviously now the development of omics technologies will allow the advent of personalized or bespoke medicine development of N1 therapeutics for each patient. So this concludes the presentation, and I would like to thank everyone who attended this lecture. So I will give a brief break and then we'll take the questions. Thank you. Thank you for attending the lecture. It was a long one, and probably, excuse me, I can talk about this for a long period of time. As a disclaimer, for the two case vignettes, obviously that is that the patient who, the Fabry patient who had a kidney transplant, the GL, the urinary GLs were actually included as a kind of to confuse a little bit and then check your background. I mean, obviously this is a transplanted patient and we are measuring somebody else's urine markers in that patient. Anyhow, so there are a few questions on the screen that I will read aloud, and then if there are more, then we'll answer them. Excuse me. So the first one is, can lyso-Gb3 be considered as a validated marker for Fabry disease? Yes, it is a validated trial level. What we call as validate is a trial level validated marker. And mm, to assess therapy effectiveness. So therapy effectiveness is a very broader term. What I would actually limit is a short-term therapy effectiveness. So we do see that the changes in lyso GB3 concentration with therapy, and if there is no change, I use that like in patients with who have actual high titer antibodies, IgG type antibodies, and then we do management changes in if the patient has increasing titers and also increasing lyso-Gb3 values. I hope this answers. The second one is actually there is a question about the biomarkers for Hunter syndrome or MPS2. So I had a slide on that with mass spectroscopy or base markers for a few disorders. Hunter was included there too. So obviously the substrate based markers that is actually we can do it in several body fluids now, including the peripheral plasma, which is more reliable than the urinary gags, which changes with age and the secretion. And the other markers that are used in the clinical trials or had been published upon are the glycosphingol-based markers actually that has been shown to increase in MPSs2. That includes GM2, GL1, BMP, and neurofilament have been recently used in the trials now as an exploratory marker, not as a validated marker. The third question that we had was whether GK's level or glucoceramide synthase, GK's level, glucocerebrosidase levels are good markers for Gaucher disease related Parkinsonism. The answer to that is there are publications on the decreased levels of lysosomal enzymes in GD-related Parkinsonism, or actually in Parkinson disease per se, were hypothesized as a general lysosomal dysfunction. GK's levels are not a biomarker for GD-related Parkinsonism, in my point of view. The reason is you may actually have it in a heterozygote carrier who may have levels as close to as normal. And then the level you can measure actually is in the lysosomal media in an, when you're doing the gross enzyme assay, and which you cannot assess the misfolding if this is the reason. But what is the enzyme? So basically, the biomarker changes from what context you're using for, whether it's a diagnostic, prognostic, and there are actually different biomarkers as FDA states for different purposes. There are diagnostic markers, there are disease prognostic markers, there are mechanism of action biomarkers. Like for a let's talk about a drug. We haven't talked about the drug mechanism of action here, like the chaperones. Okay, so we have a chaperone treatment for Fabry disease, and which in theory, chaperones do increase the enzyme levels, and if they're not used correctly, actually they do inhibit the enzyme levels. So I use GLA activity as a biomarker in patients that I treat with the chaperone for Fabry disease. So if I see that the enzyme is inhibited, it means they're not using correctly, and I expect the enzyme to be enhanced by the chaperone. So I hope this explains. I guess we don't have too much time to answer the questions, so I would like to thank everyone, and also the contributors, the sponsors for the CME quarterly meetings, including Takeda, Chiesi, and Sanofi, for their generous support of this program. Thank you very much, and I'll see you in the next one in 3 months. Thank you.